So metabolic syndrome is defined by a constellation of interconnected processes, which are physiological, biochemical, clinical, and metabolic factors. All these factors together will increase the risk of cardiovascular disease or type 2 diabetes, and all-cause mortality also is increased. In the metabolic syndrome, it is a major escalating public health disease, and it is facing clinical challenge worldwide. This is in view of urbanization and surplus energy intake, increasing obesity and sedentary lifestyle of the people. Metabolic syndrome confers almost five-fold increase in type 2 diabetes and twofold increase in cardiovascular disease. Further, it is also a risk factor for stroke, two to fourfold increase in stroke and fourfold increase in myocardial infarction. And there is twofold increase in risk of death if a person has metabolic syndrome than a person who is not having this syndrome. So coming to the history, first it is having almost about a century history. Still research is going on, and so many new markers, new factors are being discovered. And it starts with Kylin, a Swedish scientist who has in 1923 he found the cluster of this hypertension, hyperglycemia, and hyperuricemia leading to death of the people. And in 1936, Himsworth discovered the relationship between insulin insensitivity in diabetes. In 1947, Vague has found the association between this central obesity and the relation with the cardiovascular disease. In 1965, Avogadro and Crivaldi described this syndrome, which includes three components of this metabolic syndrome, like hypertension, hyperglycemia, and obesity. In 1965, Yalo and Burson, he is the one who has discovered this insulin SS, which helped us in diagnosing metabolic syndromes. Raven is the scientist who has found a cluster of this metabolic syndrome, which includes insulin resistance in that. And he coined the term as Syndrome X. In 1989, Kaplan has named it as deadly quadrant, and he has included four components in that, which includes obesity, glucose intolerance, hypertriglyceridemia, hypertension. Later, he again recoined that name from deadly quadrant to insulin resistance syndrome. Then comes in 1998, WHO has issued certain criteria to diagnose the disease, which is followed in 2001 by National Cholesterol Education Program, ATP, Adult Treatment Panel 3. It also has given a certain criteria to diagnose metabolic syndrome. In 2005, International Diabetic Federation has given again criteria to describe this syndrome. So coming to other names of the disease, it is since this 100 years of research, the metabolic syndrome has acquired so many different names like Syndrome X, dysmetabolic syndrome, deadly quadrant syndrome, insulin resistant syndrome, Raven syndrome, cardiometabolic syndrome, cardiovascular dysmetabolic syndrome, and Biebele syndrome. So then coming to the prevalence of the disease. As we see, there is 33% prevalence in women and 39% in men, respectively. And it also differs, the prevalence also differs based upon the region, urban and rural environment, composition of the body fat and sex, age, race, and ethnicity. The prevalence changes from place to place. So, a study in 2014 has said that metabolic syndrome in women, abdominal obesity is the component which is more common in women when compared to men who has hypertension as the main component in metabolic syndrome. So, it has clearly sex-based differences, and also it increases, the prevalence increases with age. Other contributing factors for this diseases like higher socioeconomic status, sedentary lifestyle, and high body mass index. According to National Health Nutrition Examination Survey, 5% among the subjects of normal weight and 22% of the people who are overweight and 60% of the people who are obese will be developing metabolic syndrome. And according to the NCEP ATP classification, the prevalence of metabolic syndrome increases to about 43% in men and 56% in men worldwide. So what exactly metabolic syndrome consists of? It basically consists of these 5 components like central obesity, hypertriglyceridemia, and low levels of HDL, hyperglycemia, and hypertension. These are the 5 main components of metabolic syndrome, based upon which the diagnostic criteria are developed by different like WHO, like NCEP, ATP classification, and IDF, based on these 5 categories. And the most common causative of this metabolic syndrome is like insulin resistance and central obesity. Apart from these 2 main factors, other factors which are responsible are genetics, lack of physical activity, and increasing age. A pro-inflammatory state of a person also will lead to metabolic syndrome. Then coming to symptoms, as such, there are no symptoms. Patient is usually asymptomatic, and we need to have a high grade of suspicion when we check a patient with these following things, like increased waist circumference, then increased blood pressure, or acanthosis nigricans. As such, they don't show up with any symptoms. So the associated diseases with the metabolic syndrome are, there is increased, as I already told, there is increased risk of cardiovascular disease and stroke and peripheral vascular disease also. There is 3 to 5-fold increase in diabetes. It is associated with non-alcoholic fatty liver disease, hyperuricemia, PCOS, and obstructive sleep apnea. So these are the diagnostic criteria, starting from WHO, which in 1998 has said the criteria being obesity, increased glucose, increased triglyceride, low HDL, and high blood pressure. So starting with WHO criteria, it says that waist hip ratio more than 0.9 in men and 0.85 in women, or the BMI should be more than 30. And impaired fasting glucose or impaired glucose tolerance, or the person might even be type 2 diabetes, diagnosed type 2 diabetes mellitus patient. When there is no mention about triglyceride in this WHO criteria, whereas it mentions that less than 35 of HDL in men and 39 in women is a risk factor for metabolic syndrome. Coming to blood pressure, the criteria is given as more than 140/90. So any of these, among this 4, any of these 3 criteria, if they are there, then they can be considered as a patient for metabolic syndrome. Then coming to this European group for insulin resistance in 1999, they have revised it with addition of triglyceride in that. The higher the value triglyceride, that is more than 150, we have to consider it as a metabolic syndrome. And it also says that 3 of these criteria should be present to say that it is metabolic syndrome. Then comes to the adult treatment panel 3. It includes obesity more than 14 inches in men and more than 35 inches in women, that is waist hip ratio. It does not include blood glucose and triglyceride, whereas it includes HDL, which is less than 40 in men and less than 50 in women, with BP more than 130/85. All these 3 criteria should be met to call it as a metabolic syndrome according to ATP. And coming to next, International Federation for Diabetes, it includes all the criteria, all the 5 criteria, and more than 37 inches waist circumference in men and 32 in women, or the BMI can be more than 30. It also says that hyperglycemia, including impaired fasting glucose, or the person can be type 2 diabetes mellitus patient, and this triglyceride should be more than 150, or the patient can be on the treatment for hypertriglyceridemia. And this HDL should, if it is less than 40 in men and less than 50 in women, or the patient can be on treatment for low HDL. And this, when coming to blood pressure, it should be more than 130/80, or the patient can be on treatment for hypertension. So any of these, among these 5, any of these three criteria, and one of which should be a central obesity among these 5, then it is considered as metabolic syndrome. American Heart Association also goes with the International Diabetic Federation, except for this waist circumference, and it also should meet 3 criteria. So these are the criteria mainly, which includes obesity, hyperglycemia, hypertriglyceridemia, low HDL, and high blood pressure. Coming to waist circumference criteria, it differs with ethnicity. And these are the weight circumference cutoff values for males and females, which are considered while diagnosing metabolic syndrome. So risk factors mainly include sedentary lifestyle or the diet, high carbohydrate and high fat diet, and like smoking, alcohol. All this comes into lifestyle risk factors for metabolic syndrome. Genetics plays a major role. Maternal factors like obesity in pregnancy also might lead to this metabolic syndrome, which is not shown in early childhood, but it shows up in as the child grows up. And insulin resistant, as discussed earlier, it is the main reason for the main risk factor for the metabolic syndrome. Increased waist circumference, dyslipidemia, as already told, increased triglyceride or decreased HDL, glucose intolerance in form of impaired fasting glucose or impaired glucose tolerance, hypertension, and central obesity is the keystone for pathogenesis, which in turn leads to insulin resistance. Other factors like IL-6, IL-1, IL-18 resistant or tumor necrosis factor, CRP, adiponectin, which are being released by the adipose tissue, also play a major role by leading to inflammation in the adipose tissue and thus leading to chronic systemic inflammation. So the same thing has been explained here. All these are risk factors like inflammation, increased triglyceride, decreased HDL, oxidative stress, abdominal obesity, prothrombotic state, blood glucose, insulin resistance. All these are risk factors which lead to metabolic syndrome. In turn, this metabolic syndrome is leading to all these associated disorders like neurological disorder, PCOS, cancers, cardiovascular diseases, type 1 diabetes, stroke, and non-alcoholic steatohepatitis. This slide also explains the same thing with the pathogenesis. So all these risk factors, obesity, genetics, and inactivity together lead to all these pathological changes like insulin resistance, inflammation, oxidative stress, and endoplasmic reticulum stress. Lipid metabolism is altered, and this fat is being deposited in the visceral organs. Mitochondrial dysfunction, AMPK and CRT, these epigenetic changes, all these pathological changes will lead to these diseases which are already discussed. And in the initial phase, it has 3 phases, metabolic syndrome, phase 1, 2, and 3. Initial 2 phases might not show much of the symptoms, but it ends up in phase 3 late where all the symptoms are seen. So this also shows the same thing. Environmental factors and genetic factors like 50 genotypes and phenotypes will lead to positive energy balance, leading to accumulation of fat in the adipose tissue, which releases free fatty acids into the metabolism. This altered, there is altered release of adipokine from the adipose tissue. So these free fatty acids are released into the circulation, which leads to increased lipoprotein synthesis like LDL and increased gluconeogenesis, thus leading to dyslipidemia. Then this free fatty acids also lead to insulin resistance and hyperinsulinemia, then further changing the beta cell function of the pancreas and leading to hyperglycemia and overt type 2 diabetes in due course of time. Then the adipocytes release this leptin, angiotensin, leptin and other adipokines. This will lead to activation of this other systems also, which include the renal system, mainly angiotensin 2 and aldosterone, leading to angiotensin aldosterone system and sympathetic nervous system activation, thereby causing sodium reabsorption, vasoconstriction, leading to hypertension. There is also through this adipokine released inflammatory process will increase and leading to this, all these factors, increase in all these factors leading to oxidative stress and leading to pro-inflammatory state and pro-thrombotic state. So then they become hypercoagulable and the risk for cardiovascular diseases and stroke increases with all these factors. So in detail, we'll check now how is the pathophysiology of the metabolism occurs. Some 2 main important factors are insulin resistance and central obesity. As first we'll see the insulin resistance. As we know, the insulin is anabolic hormone which inhibits lipolysis and hepatic gluconeogenesis, and it helps to increase glucose uptake in liver and other peripheral tissues like muscles and adipose tissue, thereby decreasing the plasma glucose concentration. So insulin resistance is already associated conditions are already established. Insulin resistance leads to all these things like type 2 diabetes, hypertension, impaired glucose tolerance, obesity, polycystic syndrome, hyperuricemias, decreased fibrinolytic activities, dyslipidemias, and atherosclerosis. Then let's check how is it exactly happening. So as the free fatty acids increase in the body, these free fatty acids will inhibit this conversion of glucose by PDH inhibition. Then glucose up by inhibiting insulin also. Free fatty acids inhibit the insulin intake into the cell, leading to insulin resistance, and glucose is not being uptaken by the cell, and thus the glucose concentration in the serum or plasma increases. And this also shows the same thing. The more and more fatty acids in the blood, more insulin is released in order to decrease the glucose. But this due to insulin resistance, this glucose is not entering into the cell, and glucose uptake is being decreased. So the glucose level is increased. Hyperinsulinemia happens. Then this pyruvate, this conversion will not happen. Glucose will be inside. The glucose inside will remain inside, and causing glucotoxicity inside. And polyols, hexoamines, and advanced glycation end products. All these things will increase, which leads to inflammation in the body. This pyruvate is again converting into melanin-CoA, and this pathway leads to the formation of lipogenesis. And the whatever pyruvate is remaining will convert into that is glucose oxidized and forms into reactive oxygen species. This free fatty acid, which is freely present in intracellular, will be converting through beta oxidation to reactive oxygen species like LDL, oxidized LDL. All these things will be released, and too much of this fat will be accumulated, leading to lipotoxicity, which can be stored in all the vessels. So insulin resistance will lead to hyperinsulinemia initially. This insulin will this will cause lipolysis by lipoprotein lipase, activation of lipoprotein lipase. That this will lead to increased free fatty acids. The free fatty acids has this effects on glucose uptake, as already discussed, and increased resistance, and it will even affect the pancreatic IL cells, leading to hyperglycemia and type 2 diabetes. So this is about insulin resistance. Coming to abdominal obesity, as all of us know that adipose tissue is a mixture of adipocytes, stromal periadipocytes, immune cells, endotheliums, and all these put together forms adipose tissue. When there is a nutrient excess, this adipose tissue either can increase in size or increase in number, leading to all the pathology in metabolic syndrome. So once this adipocyte is hypertrophied or hyperplasia, various kinds of adipokines are released, which includes hormones like leptin and adiponectin, peptides like angiotensin, apelin, resistin, and plasminogen activator inhibitor, and inflammatory cytokines, interleukins. All these adipokines are being released when there is excess of adipose tissue, excess of storage of fat in the adipose tissue. These all lead to the pathophysiology of metabolic syndrome, which is like they lead to insulin resistance and lead to the syndrome. With obesity and progressive adipocyte enlargement, the blood supply for adipocytes may be reduced with consequent hypoxia. This hypoxia will lead to the necrosis of the tissue and thereby releasing the macrophages into the adipose tissue. These macrophages again release all the pro-inflammatory mediators like TNF, IL-6, PAIs, and all these things. This localized inflammation in the adipose tissue, which propagates, and it overall it will change into systemic inflammation associated with the obesity. This slide shows the same thing. This is normal lean adipose tissue with the minimum number of these adipokines. This in case of obesity, this excess lipid is stored, and this one adipocyte becomes enlarged, and number of adipocytes also increase. They start necrotizing, dying adipocyte because of lack of oxygen hypoxia. This dying adipocytes will release all these inflammatory mediators. So lean adipose tissue has all these adipokines like increased adiponectin, adipsin, omentin, and IL-6, which try to decrease the inflammatory markers. So there is less amount of leptin-resistant bisfatin, cameron, tumor necrosis alpha, IL-6, and MCPs in a healthy adipose tissue. The opposite happens in the obese adipose tissue. So when there is all these factors in the lean adipose tissue are anti-inflammatory. Once the adipose tissue is hyperplasic or hypertrophied, all these things, inverse of all these effects happen, and it forms a pro-inflammatory place for the inflammation to occur. So this also shows the same thing, like visceral adiposity due to increased calorie intake will lead to all the increase of pro-inflammatory cytokines, adipokines, and this will lead to hormonal activation or insulin resistance and chronic inflammation. All these things will lead to diabetes and cardiovascular disease. So coming to most studied adipokine is leptin and adiponectin. Leptin acts on neutrophils, T helper cells, B cells, dendritic cells, all these cells, and they help in all these processes like increased proliferation, increased cytokinins, decreased proliferation of suppressive functions. All these things will be, so it is a pro-inflammatory. These levels are increased in metabolic syndrome. Adiponectin is opposite. So this will act upon macrophage, dendritic cells, T cells, B cells, thereby leading to increased IL-10, IL-1 beta, the tumor necrosis factor, alpha, IL-6, and MCPs. It inhibits B cell generation in long-term cultures, possibly inhibits B cell infiltration also. It helps in increasing the maturation activation of dendritic cells. And this adiponectin levels are decreased in the metabolic syndrome, thereby leading to pro-inflammatory condition. So how exactly these we'll just look at the mechanism, how exactly it's happening. The mechanisms involved in these insulin resistance and adiposity, inflammation related to adiposity are mitochondrial dysfunction, inflammation, microbiome is involved, environmental causes, circulatory microorganisms, and phytoin A is also proposed as a major cause for the metabolic syndrome. First of all, this mitochondrial dysfunction. As already we know that this adipose tissue, due to overload of fat, free fatty acid increase, and it causes overload of that, leading to metabolic inflexibility. Like all the metabolism happening in mitochondria is disrupted. Like increased TCA cycle happens, decreased ketogenesis, decreased long chain acyl carnine, decreased ATP production. This will lead to insulin resistance and lipotoxicity, leading to oxidative stress and inflammation, apoptosis, and fibrogenesis. Like already discussed, inflammatory cytokines are also increased due to excess of free fatty acids. So coming to inflammation as such, the inflammation leads to immune cells release the inflammation. This is this insulin which has to be acting by acting on the glucose transporter is not acting, leading to insulin resistance. And this hyperlipidemia or hypertriglyceridemia, hyperglycemia, all this will lead to oxidative stress. Advanced glycation end products concentration also increases. All this will lead to the IKK beta activation, which will lead to insulin resistance finally, by increasing all the biosynthesis of all these compounds, which will again lead to insulin resistance and production of cytokine, excess production of cytokines. So this slide also shows the same thing, like all this this lean body, lean adipose tissue. This is at obese adipose tissue releasing all these adipokines, activating tumor necrosis alpha and nuclear factor kappa beta. Then let's see how does the microbiome relate to the metabolic syndrome. So in healthy gut, the healthy bacteria present in the gut converts the undigested carbohydrate to short chain fatty acids, propionate and butyrate, which are healthy for the gut epithelium, and these are indirectly will stimulate the L cell, which is a neuroendocrine cell in the gut present, which will help in like which will connect this hormones released from this will help in connection with the brain directly. Then like what happens in metabolic disorders? So the gut bacteria is disrupted. The mucus present here in healthy is being decreased. There is decrease in mucus. There is no production of propionate, butyrate, or short chain fatty acids, and thereby there is no release of gut peptides from this neuroendocrine cells, leading to leakage. These tight junctions are now not tight because of this disrupted environment in the gut, leading to this lipopolysaccharide of the bacteria is released into the inside the cell, leading to inflammation. This acts as a trigger for inflammation, and all these inflammation markers again increase. Then circulating microRNAs are also involved in the metabolic syndrome. Lean like microRNA 223, 145, this microRNA 21, 155, 27, 222, all these are involved in the development of metabolic syndrome directly or indirectly. So lean body, lean obese tissue has this microRNAs, which will inhibit these tumor suppressor genes. Then by that decreasing the progression of the tumors. Whereas in obese tissue, all these microRNAs have been released, which help in angiogenesis and progression of the tumor. So fertuin A is a new marker, which is a glycoprotein, a carrier protein, which is mainly synthesized in the liver, and also it is synthesized in adipocytes and muscle tissue also. This high levels of fertuin are being established in obesity and insulin resistance. With this fatty, the adipose tissue, which is excess, will be accumulated in all the tissues like liver, pancreas, and adipocytes, which will release fertuin A, which through various mechanisms is involved in the inflammation, leading to further accumulation of fat in the liver, or decrease all the beta cell function is decreased, and thereby insulin secretion also is decreased, finally it leading to type 2 diabetes or insulin resistance. The same thing here again. The fertuin A is having effect on the liver. Further accumulation occurs, and fertuin A also will lead to low adiponectin in the blood, and which decreases AMP kinases and affects the kidney by causing albuminuria and decreased GFR. This coming to the consequences of the metabolic syndrome. Metabolic syndrome leads to fatty liver disease, lipid metabolism degeneration, hypertension, cancers, dementias, heart diseases, and polycystic ovarian disease. Let us see each one in detail. How is it causing fatty liver disease? The substrate overload from high fat and sugar intake will increase insulin and increase free fatty acid in the adipose tissue. All these things will increase the free fatty acids in the circulation, which is mobilized into the liver. This free fatty acid inhibits PPAR gene and leads to the accumulation of lipids in the liver. This high insulin also will lead to more insulin in the cell, and this will increased glucose will lead to increased generation of lipids inside the cell. Then this excess fatty acid or fats in the body will go and store in the muscle also, leading to myosteosis. So fatty liver disease continued, like all these factors like genetic factors, obesity, diabetes, dyslipidemia, environmental factors like smoking, alcohol, and unhealthy diet. This gut microbiota, dysbiosis of the gut microbiota, and sarcopenia, all this will lead to metabolic dysfunction. And finally, this will lead to glycemic dysregulation. Initially, it starts with simple fatty liver. With associated factors like dyslipidemia and genetic factors, this will go on to steatohepatitis and hepatic fibrosis. Then, how this phetuin A is causing fatty liver? This phetuin A, whenever there is insulin resistance, this phetuin A is released into the circulation and it further increases the insulin resistance. This free fatty acids which decrease the production of AMP kinases. And, this will lead to the AMP kinase actually inhibits NF-K beta, but in cases of obesity, free fatty acids cause decreased amount of AMP, thereby causing stimulation of NF-K beta, which is the reason more NF-K beta is there, and this will stimulate phetuin A mRNA to produce more phetuin A. This more phetuin A acts on the steroid retinol binding protein and leading to more amount of lipogenic enzymes are produced, leading to the accumulation of fats. And this is about the fatty liver. Coming to hypertension, how is metabolic syndrome causing hypertension? The central obesity through all these mechanisms like insulin resistance and adipokines, release of adipokines and other adipokines like leptin, stimulation of sympathetic nervous system, atrial natriuretic peptide activity is decreased, renin-aldosterone ratio is increased. This system is disrupted, and increased sodium absorption. All this will lead to endothelial dysfunction, leading to microalbuminuria and prehypertension, which ultimately leads to hypertension, CKD, CVD, and type 2 diabetes. Coming to cardiovascular disease, the same mechanisms will help in to cause cardiovascular disease. So mainly the glucose intolerance and all the derangements in the fatty acids, changes in the hemodynamics in the form of hypertension, sodium retention, and elevated sympathetic activity, and procoagulation factors elevation. All this leads to the formation of platelet plaques and everything in the blood vessels, leading to coronary artery disease. This also shows the same thing, like what are the effects of metabolic syndrome on various cardiovascular system. Like it causes tonic vasoconstriction, leading to decreased vascular flow release, decreased nitrogen oxides in the blood vessel, decreased cardioprotection, and it will lead to the congestive heart failure. This inflammation will lead to pro-apoptotic state, and the infarct size will increase. And this pro-inflammatory markers will lead to atherosclerosis and thereby causing congestive heart disease or stroke. Increased inflammatory markers like fibrinogen and PIs will lead to antifibrinotic state, prothrombotic state, and all these pro-inflammatory cytokines will be released, which ultimately lead to the damage to the blood vessel and cardiomyocyte. How is metabolic syndrome causing PCOS? This hepatic insulin resistance dietary factor will lead to increase in lipids, as already said. This will lead to the insulin resistance, and this insulin resistance will finally decrease the sex hormone binding globulin gene, that thereby causing decrease in SHBG. This decrease in SHBG in turn causes more amount of free androgen in the circulation, which will lead negative feedback and increases the LH, leading to androgen excess, and decreases FSH, leading to follicular arrest. Thereby, there is an anovulatory cycles increase. This is the pathophysiology involved in the polycystic ovarian disease due to metabolic syndrome. So coming to cancers, So these are various types of cancers which are being studied in metabolic syndrome. With as already said, the minimum 3 components are required to diagnose this metabolic syndrome. Even with the 1 component, 2 component, 3, 0 component, also the cancer uh, uh, is increased. Like we see, it is mostly affecting. The more number of the components, more is the incidence of these cancers like colorectal cancer, liver cancer, pancreatic cancer. All these cancers are being proven in the studies, with exception for this premenopausal breast cancer. Rest everything increase with the increase in the number of components of the metabolic disease. So possible mechanisms involved in cancers in metabolic syndrome is insulin resistance, which will stimulate insulin-like growth factors, and hyperinsulinemia, which along with the IGF-1 inhibits sex-binding globulin synthesis, thereby leading to increased bioavailability of sex hormones. And this may have a role in hormone-dependent cancers, like mostly it is breast, endocrine, and prostate cancers. So this insulin is a major anabolic hormone that stimulates cell proliferation, and its effect on cancer cell proliferation is suggested to be with the IGF-1 stimulation. The growth hormone is a primary stimulant of IGF-1 production in liver and insulin, which stimulates IGF production in the liver by upregulating the growth factor receptors. This hyperinsulinemia also increases IGF-1 availability by decreasing hepatic secretion of IGF binding protein 1 and 2. So these are all upregulated in the breast cancers and colon cancers. So cytokines and prostaglandins like cycloogenase 2 is also overexpressed in the cancers like colon and breast. Pro-inflammatory cytokines like TNF alpha, interleukin 1 beta activate the IKK beta and NFK beta pathways, thereby causing insulin resistance. And these inflammatory markers are related with most of the cancer types like gastric, pancreas, esophagus, liver, gallbladder, and colorectal cancers. So how is this mechanism happening? In normal tissue with increased oxidative stress and reactive oxygen species, nitrogen species, and uric acid will transform and progress with the decreased xanthine oxide reductive expression and altered adipokines to proliferation of the cell by thereby causing increased purine salvage pathway and increasing insulin sex hormones. This proliferation will further lead to angiogenesis. The pro-inflammatory markers will lead to this angiogenesis, finally leading to metastasis of the cancer cell. So this slide also explains the same, like these are the visceral adiposity, hyperinsulinemia, IGF and IGF receptor axis, inflammation, estrogen signaling. All these will lead to the tumor progress, angiogenesis, and metastasis. Coming to neurological involvement in the metabolic syndrome. So this metabolic syndrome mainly impairs the cognitive function of the brain. This insulin resistance through PI3K will lead to the this PI3K activated inhibits the protein kinase 3 pathway, thereby inhibits this one, which is leading to glycogen synthase kinase beta and the hyperphosphorylation of the top proteins in the brain. And the advanced glycation end products also will lead to the hyperphosphorylation of the GSK3 beta and top proteins. And this NADPH oxidase will help in like production of superoxides and hydrogen peroxides, thereby leading to effect on the amyloid beta pyrophosphate and causing amyloid plaques to accumulate in the brain tissue, leading to this cognitive impairment. So these are the reactive oxygen species which are released in the stress. This will affect the cells in the brain, causing DNA damage, accumulation of this insoluble proteins like amyloid beta, and cause senescence, apoptosis, neuronal plasticity dysfunction, blood-brain damage, and inflammation. All these things will lead to neurodegenerative disorders. This one slide shows that how this metabolic syndrome is causing all the neurodegenerative diseases like Parkinson's, Alzheimer's, and amyotrophic lateral sclerosis. All these things by altering the uh, intracellular milieu. Like hyperglycemia is leading to impairment in the calcium and nitric oxide, and modification of these proteins like TRP1 and ID1, which will affect the catabolism of insulin and amyloid beta, thereby causing the changes in the dynamics of these proteins, leading to the accumulation of all these products in Alzheimer's disease. Likewise, in insulin resistance and type 2 diabetes, there is synaptic loss, which is leading to Alzheimer's disease. Again, uh, altered RAS factors will lead to cardiovascular and metabolic phenotypes, leading to cognitive impairment and dementia. And metabolic syndrome has high plasma triglyceride levels and impaired cholesterol release in neuron, leading to neurofibrillary tangles, and this leading to the Alzheimer's and Parkinson's disease. So in likewise, all these metabolisms whichever are involved in the metabolic syndrome will lead to neuronal toxicity and accumulation of all these proteins in the cell, leading to the neurodegenerative diseases. How is this metabolic syndrome causing obstructive sleep apnea? Metabolic syndrome by all these common modalities increases the sympathetic nervous system activity, increases the cortisol, and this dyslipidemia leads to hypoxia and vascular dysfunction in sympathetic nervous system, weight gain, and left resistance by increasing the ghrelin levels. All these things will finally lead to the anatomical obstruction or altered ventilation or collapsibility of the airway, leading to obstructive sleep apnea. Then hyperuricemia is also caused due to metabolic syndrome. This is a mechanism by which hyperuricemia will affect the organs. Hyperuricemia will lead to sympathetic activation, renin-angiotensin system activation, and oxidative stress and inflammation, thereby leading to endothelial dysfunction, decreased nitrogen oxide, increased reactive oxygen species, and all these things will lead to the endothelial dysfunction. In the same way, it impairs the coronary artery blood flow, diastolic relaxation, and ischemic reconditioning. In the same way, this hyperuricemia leads to increased aldosterone, increased angiotensin 2 and NADPH oxidase NOS production, thereby hyperfiltration of the kidney, leading to sodium retention, glomerular sclerosis, tubulointerstitial fibrosis, proteinuria, and decreased GFR. So coming, this is mainly about the pathophysiology of the disease. Coming in brief about the diagnostic criteria, apart from this abdominal obesity with the waist circumference criteria or more than 30 BMI, associated with blood pressure, high blood pressure, or impaired fasting glucose and HbA1c, or any abnormality in the lipid panel, along with this confers the metabolic syndrome. Other components also can be included, like urine glucose tolerance test, creatinine, urine albumin to creatinine ratio, abdominal ultrasound, ALT, AST, PLT in case of NAFLD, and serum uric acid in case of impairment of the renal system. All these are special tests which can identify the coronary vascular diseases or fatty livers or PCOS. The special tests, we can go ahead with the special test if we have doubt in particular involvement of the organ. Next, laboratory markers, as already we know, blood glucose, lipid profile, left is uric acid, are the common tests which we do for this metabolic test. Then comes the insulin resistance. Insulin resistance we can know by fasting insulin levels or fasting glucose value by these two values we can use to calculate insulin resistance through HOMA-IR or quickie methods. Actual gold standard method is euglycemic lamp method, but this is laborious and takes more time and it's complicated method. So we have used HOMA-IR or quickie method as an alternative to know the insulin resistance. So adipose tissue markers like leptin, adiponectin also can be analyzed. Increased leptin and decreased adiponectin values are seen in metabolic syndrome. To know the atherogenic dyslipidemia, we can do apolipoprotein B. In case of there is doubt in the diagnosis of type 2 diabetes mellitus, we can go ahead with the OGTT. We can do pro-inflammatory markers like HSCRP, tumor-necrosis alpha, tumor factor alpha, IL-6. Pro-thrombotic markers like plasminogen activator inhibitor 1, fibrinogen, and marker for vascular degeneration is microalbumin. And in case of PCS, we can go ahead with the hormonal profile. Treatment, and just outline of the treatment in the metabolic syndrome. Obesity, impaired glucose regulation, hypertension, or dyslipidemia, these are the targets for the treatment. So initially we give suggestions for dietary modification, exercise, and cessation of smoking and alcoholism, and to have a good sleep also. And first, coming to the obesity, if it is more, BMI is more than 27, then the treatment target is weight loss, or otherwise glucagon-like peptides we can give. Step 2 is if it is not responding to these things, and we can go ahead with orlistat, which decreases the absorption of the excess food. And if all these are not working, then we can go ahead with the metabolic or bariatric surgeries. Then in case of impaired glucose regulation, so if it is HbA1c is less than 7, actually the criteria is less than 6.5, we can consider giving them treatment with the metformin first, and then other medications according to the patient's glucose levels. And then in case of hypertension, we can add ACE inhibitors or ARBs or calcium channel blockers or thiazolidine ions, depending upon the patient condition. We can add each drug. Then comes the to decrease the LDL levels, we can add statin or fenofibrates or omega-3 fatty acids to the patient. So this is in brief. I'm not going in detail about this treatment. In summary, this metabolic syndrome main risk factor is abdominal obesity. Like if it's normal, there is no problem. As and when the abdominal obesity is increasing, all these conditions are coming out, like dyslipidemia, prediabetes, and hypertension. These are the criteria for diagnosis of metabolic syndrome, which finally lead to the all these diseases which we have discussed already. So main factors: insulin resistance, obesity, this hypothalamo-pituitary axis dysregulation, and dyslipidemia. All this will lead to the insulin-resistant chronic inflammation and changes in the hormones, and all these things will lead to the metabolic syndrome.